I presented data about monoclonal gammopathy and smoldering, so early stage of the disease, so pre-malignant disorders. The problem of this pre-malignant disorder is that they can potentially evolve to active myeloma. So monoclonal gammopathy includes the presence of a small monoclonal component, and the plasma cell bone marrow infiltration is very low, and the risk of progression to myeloma is very low and uniform over the time. So when we do the diagnosis of monoclonal gammopathy, so we have to follow just the patients probably every year, and it is not necessary to do anything else because the risk of progression is very low. However, if we move to smoldering, smoldering is an intermediate disease between monoclonal gammopathy and myeloma, and it includes a monoclonal component higher than 3 grams and or a plasma cell bone marrow infiltration higher than 10%, between 10 and 60%. The problem for patients with smoldering myeloma is that the risk of progression to myeloma is not uniform. So there are, I would say, 3 different subgroups of patients: patients at low risk, patients at intermediate risk, and patients at high risk. So you can imagine that patients at low and intermediate risk can be followed like MGUS-like patients once per year, but the problem is the patients that have a high risk of progression to myeloma. I am talking about 50% of risk of progression within the first 2 years after the diagnosis. So in these patients, we can plan to do a close follow-up, but also we can consider the possibility of early treatment to try to prevent the progression to myeloma in order to delay the time to progression to active disease. And in line with this, the Spanish myeloma group reported the results of a phase 3 randomized trial conducted in this group of asymptomatic myeloma patients, but at a high risk of progression to myeloma. And we decided to randomize the patients to receive early treatment with lenalidomide and dexamethasone versus no treatment. And what we reported is that the early treatment with lenalidomide and dexamethasone resulted into a significant benefit in terms of delay of the time to progression to myeloma, but this benefit also translated in terms of overall survival, and in addition with a very acceptable toxicity profile. So at the present time, there are many clinical trials conducted in high-risk asymptomatic myeloma patients, and we consider that in the near future, we will offer early treatment to all asymptomatic myeloma patients, but at a high risk of progression to myeloma. Yeah, this is an interesting question. So we can use the M component as well as the plasma cell bone marrow infiltration, and the Mayo Clinic built a risk model based on these 2 features. And we know that when one smoldering myeloma patient has a monoclonal component higher than 3, and the plasma cell bone marrow infiltration is higher than 10%, the risk of progression is high, 50% at 2 years. In addition, the Spanish myeloma group built another different model evaluating the plasma cell bone marrow compartment by flow cytometry. And we identified that most of the plasma cells were aberrant, and when this occurs, and in addition the patient has immunoparesia, the risk of progression is also very high. But there are another different features that we can use to evaluate the risk of progression, like cytogenetic abnormalities, or even PET-CT. PET-CT is a new imaging assessment valid for the evaluation of bone disease in myeloma. We know that when one smoldering myeloma patient has PET positive with no lytic lesions in the CT part, the risk of progression to myeloma is also high. So we can use different risk models, but I would say that it's easy to identify the risk of progression to myeloma. This is an important question, and so I don't have the definite answer at this moment. What I can say is that in the trial we conducted, when we published the first time this trial in 2013, the median follow-up was 40 months, so 3 years approximately, and the benefit was very evident. Now we have just updated this series, and the median follow-up now is almost 7 years, and the benefit is so evident as well. And in fact, most patients in the control arm have already progressed to myeloma, whilst only 25% of the patients in the experimental arm have progressed. So I think that these results are very encouraging, and in fact we are now conducting another different trial in high-risk smoldering myeloma patients, no randomized trial, because we consider that there is not ethical to consider observation for this group of patients, and we have planned a much more aggressive option of therapy, including 3-drug-based combination, transplant maintenance, and our objective would be to cure some of these patients. This is our local study, but there are another international trials using ilotuzumab plus lenalidomide and dexamethasone, daratumumab, carfilzomib, lenalidomide, dexamethasone plus daratumumab. There are many trials currently ongoing.